This is the presentation for the stomach, GIT 4. Causes of gastric ulceration: bacterial, aspirin, Crohn's, and Zollinger-Ellison syndrome. An ulcer without mass, just an ulcer. Are the examples. An ulcer is a fleck of barium. An ulcer is a barium-filled protrusion. The mucosa going to the ulcer are radiating smoothly, no interruption, they are continuous. To differentiate this from masses, ulcer in a mass will show interruption of these lines, but ulcer protruding on the surface is usually showing continuous mucosal folds radiating from the ulcer itself. So we have an ulcer niche or ulcer protrusion, we have a fleck of barium, we have the corona radiata sign, and we have the sites. The sites are the lesser curve or otherwise the greater curve. The greater curve ulcers are usually malignant, while the lesser curve ulcers are usually benign. A small ulcer is usually benign. A big ulcer could be malignant. These are ulcers without masses. The causes of ulcers without masses: the chronic gastric ulceration, the aspirin, the Crohn's disease, and Ellison-Zollinger syndrome, Zollinger-Ellison syndrome. If we find a target lesion means that there are something inside a something, ring showing fleck inside. It could be due to deposits or Kaposi sarcoma or melanoma. So the three are malignant. So target sign in the gastrointestinal tract is due to malignancy, and this is the appearance. To differentiate this from the other one, we have the one we show the ulcer protrusion with the mucosa radiating, and we said that continuous mucosa is denoting benign lesion, while this interruption of the mucosa around denotes malignant lesion. So this is a malignant process. These are the edges of the mass, and this is the ulcer itself. So this is an ulcer within a mass, not an ulcer without a mass. This is an ulcer within a mass. Mass is forming the filling defect or the interruption of the mucosa, and finally this appearance is called target sign. Target sign. So to repeat again this part, we have gastric ulcer without masses, either due to bacteria or chronic gastric ulceration, aspirin, Crohn's, Zollinger-Ellison syndrome, and the appearances are like this. Either we have a protrusion of barium with the mucosal convergence or corona radiata sign, or we have the fleck of barium, dense fleck of barium within the ulcer itself. These two are examples of chronic gastric ulceration without masses. Now, for differentiating between benign and malignant, the presence of smooth continuous lines radiating from the ulcer itself are definitely pointing to benign nature. A small ulcer is usually benign. Larger ulcer could be malignant. Ulcer on the lesser curve is usually benign. Ulcer on the greater curve is usually malignant. So we have these differences, and this is the appearances. The target sign, that means that we have lucent area, defective area with an ulcer inside. It could be due to hematogenous metastasis, it could be due to Kaposi sarcoma, it could be due to melanoma, so all are malignant. So the presence of such an appearance with a filling defect and no mucosa going to the ulcer, no mucosa, this area is the mass itself. So denotes that there is a mass with an ulcer inside. A mass with an ulcer inside is usually malignant. When we have thickened gastric folds, it could be due to gastritis, it could be due to lymphoma, it could be due to lymphoid tissue, it could be due to Zollinger-Ellison syndrome, again with hypertrophic mucosa, or it could be due to varices, and this is the smooth type of folds. So in this one we have gastric rugae. This is the cleavage between a rugae and the other one. This is the rugae itself, this is the rugae, and because they are bulging into the lumen, they are devoid of barium, and the line in between represents the intersection between two rugae, so it is lined or outlined with barium. So what is barium is the intersection line between two rugae, and what is black is the raised hypertrophic rugae. These are thickened gastric folds in lymphoma. Now we go to gastric non-distensibility. Of course, the first cause for gastric non-distensibility, that means that the stomach is not able to distend. And to detect this, it is better to be seen on fluoroscopy. In fluoroscopy, we have some peristaltic waves along the stomach. In such case, it will be absent. There will be no peristaltic waves. And at the same time, once the stomach start peristalsis, we will have some part called incisura angularis between the body of the stomach and the pylorus of the stomach. So we have fundus, body, pylorus, and the pylorus. Between the body and the pylorus, there is some invagination called the incisura angularis. In gastric non-distensibility, all the peristaltic waves will be absent, the volume of the stomach itself will be less, and there will be disappearance of these normal invaginations. The first possibility will be cancer, lymphoma, atrophic gastritis, scarring will produce. Scarring and atrophic gastritis are something similar to each other, and they are related to fibrosis, and the other two is related to infiltration, whether carcinoma infiltrating into the wall or lymphoma infiltrating in the submucosa. This is the typical example of gastric non-distensibility, or what is called as Linitis Plastica. They are similar synonyms, and we have here the cause as carcinoma of the stomach. That's why we have this irregularity along the outline. And here the type of carcinoma is the creeping type of carcinoma. You know that carcinoma in the stomach could be creeping along the wall, could be cauliflower mass inside the lumen, or could be annular at the region of the pylorus usually. So we have three types. This is one type, is the creeping type of gastritis, which we can see, and reducing gastric non-distensibility, or what is called as Linitis Plastica. And this is a list, another list of Linitis Plastica. If you spell Plastica, it is the same. Linitis Plastica means limited capacity of the stomach. If you spell the word Plastica, get P for pancreatic tumor, L for lymphoma, A for amyloid is something just put for completing the word, S for sarcoid and syphilis, which are very rare and not seen nowadays, T for TB, and this again something away from diagnosis. Now corrosive, ingested corrosive, and cancer stomach. So just for fun, it's put as plastica, and the three important reasons for Linitis plastica are cancer stomach, corrosive, and lymphoma. Cancer stomach, corrosive, and lymphoma. If we have obstruction at the gastric outlet obstruction, we have some reasons. The most two common reasons are ulcer and non-ulcer. Ulcer is that means it may be acute or chronic, causing spasm, and finally stenosis or obstruction. It is according to the degree of fibrosis at the region of the ulcer. If it is just an acute one, you will see a spasm. If it is something chronic early, it will result in outlet stenosis, and if it is something old and chronic, it will result in a complete obstruction and huge stomach reaching into the pelvis, but the region of the ulcer is cicatrized, atrophic, and obstructing. The second cause is carcinoma. So we have ulcerations and carcinoma. And the third is gastric volvulus, in which we can have a huge gastric dilatation, but the main point here is that the cap is directed posterior. Antral diaphragm or web is rare, and pyloric stenosis in children, you know about it. It is the hypertrophic pyloric stenosis of children. So we have ulcer, cancer, and volvulus. Ulcer, cancer, and volvulus. Ulcer, cancer, and volvulus are the main causes of gastric outlet obstruction, plus that one occurring in children, which is the hypertrophic pyloric stenosis. So what is this? It is if you say 1 hour after start of upper GI examination and you still have this dilated stomach and the cap is going towards the spine, and here there is long pyloric canal, it will be hypertrophic pyloric stenosis in a child. Now going to this area again, hypertrophic pyloric stenosis can only stop here, or you can see only one line and nothing here, or you are able to see the whole thing, cap and canal. But in this type, this canal is more than half a centimeter and it is elongated. Elongated pyloric canal is a cause of is a manifestation of hypertrophic pyloric stenosis. Sometimes we find the stomach is markedly dilated, and markedly dilated stomach is a manifestation of electrolyte imbalance, neuromuscular incoordination, after surgery, after trauma, or in diabetics. So gastric dilatation could be post-operative, post-traumatic, old age, and diabetic, because electrolyte imbalance is usually due to any of these other three. So the main will be post-operative, post-traumatic, and diabetics. The main causes for old age and diabetic. The main causes of gastric dilatation is post-operative, post-traumatic, old age, and diabetic. This electrolyte is following any of the four. This is an appearance of a markedly dilated stomach filled with air, outlined with air, and this is the duodenal cap. So the duodenal cap, canal, pylorus, and body. Now, when to get widening of the retrogastric space? Widening of the retrogastric space. Any pancreatic mass can do, any retroperitoneal mass can do. If the stomach itself has a tumor which is partly in, partly out, this is called exophytic gastric tumor. That means that a tumor bulging from the gastric wall, and lastly aortic aneurysm. So widening of the retrogastric space is coming from the word gastric. It is gastric tumor, exophytic, and retro is the pancreas and the aorta, and retroperitoneal lymph nodes or masses. So it could be gastric exophytic mass, or could be retrogastric pancreatic or aneurysm or lymph nodes. Ironing of the region of the pyloric canal, ironing and duodenum. It's called Antral Pad Sign, or ironing. Ironing means that stretch of this region of the pylorus and canal and duodenum are usually due to pancreatic lesions, pancreatic cancer, pancreatic pseudocyst. But gallbladder dissension will reduce invagination of this area. And this is the example. If we have this ironing, this is called ironing. If you see this ironing, that means the mucosa is stretched. The mucosal stretching of the pylorus, canal, duodenum, as this appearance is usually due to pancreatic lesions, pancreatic mass or pancreatic pseudocyst. Sometimes we get a lesion like that, starting in the pylorus, reaching into the region of the cap, and it is, as seen here, only a tract in the middle and irregularity on either side. So it is similar to the apple core appearance, and of course this is an annular carcinoma. The causes of such lesions that cross the pylorus could be carcinoma, could be lymphoma, Crohn's, peptic ulceration disease in cicatrization, and the other two are rare. So you can concentrate on these four: lymphoma, carcinoma, Crohn's disease, peptic ulceration, starting with carcinoma. As you see, the most two frequent diagnoses till now are the carcinoma and the peptic ulcer disease and its complication. So this is an apple core appearance. This is the central part, and these are the irregular masses involving the pylorus and extending into the cap. Multiple duodenal filling defects. Multiple duodenal filling defects are usually due to lymphoid tissue. Lymphoid tissue could be hyperplasia, and this is called Brunner's gland hyperplasia. Could be due to lymphoma, or the mucosal cell, the secretory cell itself. It's called polyps. It will form adenomatous or hyperplastic types. So we are here left with two main lesions, either from lymphatic origin, or from mucosal origin. From the lymphatic submucosal origin, these are the Brunner's hyperplasia or lymphoma, and from the mucosal origin is the polyps or the adenomatous, which could be adenomatous or hyperplastic. So multiple duodenal filling defects are usually due to either submucosal or mucosal. Submucosal are lymphoid in origin, mucosal are adenomatous and hyperplastic polyps. And this is the appearance of such duodenal filling defects. We can find these multiple filling defects as this polypoid lesion. In all cases, we are not able to know the exact origin, and so biopsy will solve the problem. These are polypoid filling defects, but the causes should be in our mind. It could be lymphoma, it could be adenomatous polyps. Of course, the duodenal folds could be thickened like the gastric folds, and we will put gastritis and varices, lymphoma, and we add here pancreatitis and chronic renal failure, which can cause edema of the mucosa or submucosal edema. To find a thickened fold, it could be submucosal infiltration, submucosal edema, or submucosal invasion. In submucosal infiltration, it could be infiltrated with lymphomatous tissues or inflammatory changes like duodenitis and Zollinger-Ellison syndrome, or lymphoma with lymphoid infiltration. It could be due to elevation of the mucosa due to varices, as in the esophagus, lower esophagus and the stomach, or it could be due to edema, as in chronic renal failure and pancreatitis. Here we have the coarse duodenal mucosa or thickened duodenal mucosa amounting to filling defects. This one is due to lymphoma. We can see the extension of the defects along either side of the duodenum, this area and that area, and here the mucosa appears markedly thickened. This is due to edema of the mucosa. Duodenal or Duodenal-Biliary fistula. If you find filling of the duodenal of the biliary, common bile duct with barium during barium swallow, or during upper GIT examination, it is either due to post-operative changes or due to something infiltrating and making a communication like gallbladder carcinoma and duodenal carcinoma. So this is the appearance. Now they are filling here, filling the duodenum, and at the same time the biliary system is opacified. It's either due to post-operative change or malignant process. Post-operative or malignant. This is the one with the large duodenal loop, dilated duodenal loop. This is the cap. This is the incisura angularis, and this is the peristaltic wave, and this is the pylorus, canal, cap, apex, second part of duodenum, third part of duodenum going to fourth, and there is obstruction here. It's not continuous. The rest of the jejunum is still not filled like that one. So this is part of the jejunum. What are the causes of duodenal obstruction? The cause of duodenal obstruction could be due to congenital duodenal atresia or stenosis, but this is supposed to be in infancy. An annular pancreas can do, volvulus can do, spulomesenteric artery syndrome, carcinoma, and intramural disease, intramural infiltration or hematoma or lymphoma. So the main things are either congenital in atresia and stenosis, and this is infancy. Annular pancreas can be seen, carcinoma could be, and one of the most important is the spulomesenteric artery syndrome, in which you find dilatation with abrupt stoppage of the barium like this, and it forms like a line, transverse line across the duodenum. This could be due to spulomesenteric artery compression. Here you don't find any infiltration or disease process in the wall. The wall is healthy, the mucosa is healthy, and there is abrupt obstruction. So spulomesenteric artery syndrome is more likely, but as we said, it could be due to annular pancreas, which is not the case. Here we find the reverse, that the duodenal loop itself is markedly widened, and again we can say ironing, the ironing of the mucosa of the pylorus, ironing of the mucosa of the duodenum. Ironing means stretch. It could be due to, of course, first possibility pancreatic mass, second possibility pancreatic pseudocyst, and third possibility we can put all what can happen here at the region of the retroperitoneum. Retroperitoneum is showing either an aorta with an aortic aneurysm, or pancreas with pancreatic mass or pseudocyst, or lymph nodes. We can get the retroperitoneal lymph nodes. And don't forget that there are some congenital anomalies related to the bile duct, is called the colidical cyst. So we can gather all together as this. We can have pancreatic disease like pancreatitis, pseudocyst, and tumor. We can have lymph nodes. We can have aortic aneurysm and colidical cyst. Thank you.